Today on The Soul of Life, I give a crash course on medicine for the mind with Dr. Joel Bernanke, a Columbia and Cornell-trained psychiatrist. We cover the power, potential, and pitfalls of psychopharmacology and its alternatives. We try to alleviate some of the common fears and expose misconceptions that stop people from treating their mind like any other part of their body. And we especially talk about treatment for depression, anxiety, and one of Dr. Bernanke's research areas, ADHD.
Physical symptoms are probably a neglected component of depression. There's this strong, what I think generically we might call the mind-body connection, but lots of people with depression and anxiety have significant physical symptoms.
As a clinical psychotherapist that's treated depression and anxiety for over the last 20 years, I was the last person I'd expect to hold on to mistrust and fear about taking medicine for the mind. It wasn't until my own body started having strange neurological symptoms, and I'd spent about a year exhausting fringe medical theories to avoid admitting that I was suffering from good old depression. And I embraced medicine for the mind and experienced a rapid remission. I'm still on a journey with my symptoms, but turning to medicine unlocked a whole world of insight into my condition that otherwise would have been unexplored. Dr. Bernanke and I will hopefully give you a glimpse into how to navigate behavioral medicine to help you get help for you or your loved ones. This is an especially important topic during the pandemic. Recently, the Journal of American Medical Association published results from a survey that found prevalence of depression symptoms in the U.S. increased more than threefold during the COVID-19 pandemic, from around 8% of the population before COVID-19 to about 28% during COVID-19.
Maybe you have problems concentrating, difficulties, motivation. It might be just really hard for you to make lifestyle changes. It might be really hard for you to engage meaningfully in a psychotherapy. And the evidence supports that that's where we see really profound benefits of medication.
Dr. Bernanke and I aren't pill pushers. In fact, we talk about how to assess the cost-benefit analysis and other more simple interventions that should be exhausted before turning to medicine.
We're medical doctors first, we're humans second, and we're psychiatrists third. If someone comes in the door and says, look, I'm having this crushing chest pain, we don't say, tell me about your mother. We say, go to the emergency room and make sure you're not having a heart attack.
Lifestyle changes are proven to prevent or help us out of anxiety or depressive disorders. We know this. Things like sleep hygiene, getting 8 continuous hours minimum per night, cutting out alcohol, getting regular cardio exercise, opening yourself up to friendships, learning new skills. These are the things that really help. Swapping anxiety-provoking forms of relaxation, like cable news, with proven practices like mindfulness and yoga. These things work. They're proven to be cornerstones of a healthy mind. But in my experience, people, men especially, and I've been one of them, think that getting help is for those people, those poor souls who lack the gumption to find their own way. Or I hear things like, I'm not going to let Big Pharma trick me into thinking I need some pill to be happy. Well, today's episode is for those doubts and questions, for those of you seeking answers to make your life better, and for you and your family's future to be a little brighter. Today, we're going to sort through some of these normal fears and correct misinformation about mental health treatment.
People subject psychiatric medications to a bit of a double standard, So like people get prescribed a blood pressure medication, it doesn't quite work, they have to try a different one. That one doesn't quite work, they wind up on 2 blood pressure medications, the blood pressure comes down a little bit, but they still have a problem. Maybe they still have a stroke or they still have a heart attack. And nobody says, oh, well, we shouldn't believe in cardiology.
We talk about whether genetic testing is the future for a more precise form of psychiatric treatment.
I have strong feelings on this one. So I helped host American Psychiatric Association debate about the clinical utility of genetic testing in psychiatry.
And in addition to other shop talk between Joel and I, like medication side effects, the debate about mental health and regular marijuana use, self-medicating with alcohol, we talk about ADHD treatments, the safety of pediatric psychiatry, and something pretty interesting that I've run into myself called California rocket fuel.
And it was used in this really big community study called STAR-D. I think people have thought for its effectiveness and also for the diverse ways that it affects brain functioning, have dubbed it California rocket fuel.
Welcome to The Soul of Life. I'm Keith Miller, and this is episode 16, Medicine for the Mind.
Miles and miles of the clear blue skies. We drive straight as a narrow flies. Nowhere to be, no dreams to chase tonight. We've got time to waste, let's waste it right.
I'm Keith Miller, and my podcast, The Soul of Life, is here to help you remember who you really are. I'll bring together people who have gotten off their treadmills. I'll have conversations with athletes, musicians, doctors, scientists, healers, and entrepreneurs to discuss the fascinating edges of our knowledge in neurobiology, psychology, and physics. This is The Soul of Life. I'm really excited to have Dr. Joel Bernanke here. He's a child, adolescent, and adult psychiatrist in Brooklyn Heights, New York. He's Columbia and Cornell-trained, board certified, and he works with children, adolescents, and adults. And I'm really excited to talk with him today about the idea of psychopharmacology, mood disorders, ADHD, the whole world of taking medicine for your mind. So welcome, Joel. Glad to have you.
No, thank you, Keith. Thanks for having me on.
Yeah, I'm really excited to talk with you. You know, I've known you for a little while and shared with you some of my journey that I've shared with the listeners of this podcast about how for me taking medication for my mind and for my health was new to me, even though I've been a clinician for 20 years treating people with depression. I shared with you how at one point my body started breaking down in a certain way and I had these neurological symptoms. So I'm excited to talk to you about and make available this conversation for others who may be going through something similar to talk about, you know, how it really works. How do medicines, antidepressants, anti-anxiety medicines actually work, or at least what we know about them? And excited to talk about that and also talk about your work with children. That's another important topic to me and I think to many people out there. So I guess I'd start out with asking about like how common you think it is. You know, I shared with you that my story is related to what we could just call sort of burnout. And I think people use that term without really wanting to use the term depression. So what's your experience as a psychiatrist that treats depression for a living, right? How often do people try to dance around this word depression?
Oh, I think the answer is a lot. And I think that you're pointing out a ongoing controversy in the area of burnout studies as to whether depression and burnout are really two different things or not. There's definitely a burnout syndrome that seems to have a lot in common with depression, and there's a burnout scale that seems to assess a lot of the similar symptoms. But I think a lot of people in the field feel that burnout, although similar, is distinct from depression, but it's hard to get good evidence to sort of prove that one way or the other. So you raise an interesting point. Even the use of the term burnout is maybe one of those examples of people dancing around what might just otherwise be called depression.
Right.
Yeah. And the other way that comes up is just the different ways that people express feeling depressed. And physical symptoms are probably a neglected component of depression. You know, there's this strong, you know, what I think generically we might call the mind-body connection, but lots of people with depression and anxiety have significant physical symptoms. You know, low energy or fatigue are included right in some of the definition of depression, and muscle tension is included in the definition of generalized anxiety disorder. But I think we know that there's a lot more than that.
Right.
Right. And especially across like cultures, you know, not just racial ethnic groups, but also across cultures. You know, I think we even have some stereotypes about how men express things versus how women express things. But just the notion that individuals might express their psychic pain through their body, you know, so I'm sorry, that was a little bit of a rambling answer, but
no, it's really helpful. And I'm particularly tuned into the idea that, that the symptoms in the body, the somatic symptoms and what we would call somatization of symptoms, right? That's like the expression of symptoms through somatic experience. That is a key part of depression. I think when I didn't like to think of myself as depressed. I still kind of use I find myself kind of, if I share it with people, I kind of say it's a form of depression, or it's a subtype, or I even like to use the word subclinical depression. I throw that in there, like as if it like doesn't quite meet the standard classical, like crying every day, can't get out of bed, and these sort of moods that just sweep over, because that's not how I experienced it. And so I find myself wanting to put these qualifiers on it to say, well, it's a form of depression. It's some sort of physical manifestation of, but the point for me was like, at a certain point, I just needed to get results. Like I was not getting results. I was seeing a debilitating effect in my ability to concentrate, find words, common words. And it was scary. And then when the neurologist started telling me, hey, you're losing sensation in your hands and feet. And I wonder, I wonder if that's not a common subset of depression, right? I want people to make sure they can distinguish that.
As far as I know, losing sensation is not common, but cognitive changes are extremely common, and are perhaps another neglected area where we often overlook the residual cognitive symptoms of depression, and specifically what you're talking about. Reduced concentration is, again, one of the diagnostic criteria for depression. But I think that there's a lot of cognitive symptoms related to all kinds of psychiatric disorders that we often don't see as either the core of the disorder, or we don't do our best to identify and treat when the other, perhaps more visible symptoms are improving. So what you're talking about with like word finding, concentration, fatigue, and general physical symptoms, often most commonly aches, pains, stomach problems, those are all, I think, for a lot of people, a big part of mood problems.
Right. And insomnia too, right? That's
and insomnia. Yeah. Hugely common. And this categorical, yes, you have it, no, you don't, cutoff is really challenging.
I think you're right. People are confused. I know with my clinical experience, people, there's resistance, right? And I certainly was one of those patients where I was like, no, it's not that. Like take that checklist somewhere else. Like I went through the checklist with myself and with colleagues and with my own therapist. No, it's not depression. But then if you start to take off the rigidity of these, like you said, categories, and begin to look at like the constellation of symptoms, then that's where the crosshairs kind of settled very neatly for me on, I could embrace treatment for depression and probably get the results. So whatever you want to call it, okay.
Yeah, and as a clinician, you're exact. I try to meet patients where they're at, and I try to use whatever language feels right to them, and I try to explain to them, why I think what I think and what I think is sort of worth trying. But fundamentally, psychiatry remains a pretty mysterious field.
Yeah.
And we have a lot of data about things that work for these well-defined conditions. But we also have a wealth of data that's not randomized controlled trials to support the use of medications in, these unusual, less common presentations, or people who, are maybe on the borderline between, sort of what might be normal sadness versus overt depression.
Right.
And so that's where I think clinical experience and judgment and collaboration with a patient come into play, right. And just sort of exploring together, like, okay, what does the patient think this is? Yeah. How do they define it? What do they think is worth trying? And how do we have a conversation to help them move in a direction that we think is likely to be beneficial to them?
Right. And I went down a path that I wouldn't recommend other people doing. I got so many other recommendations from other doctors, psychiatrists. Psychiatrist was last on my list. Neurologist was next to last on my list. But I went to the endocrinologist, I went to the cardiologist, I went to the, you name it. And I won't get into it all here, but to try to rule out other things. Now, it's typical, right, for you to recommend that somebody gets a physical. Like I want people to understand that I'm not, and I don't think you are either. Like we, as clinicians, we do not, the old cliche that, if all you have is a hammer, then everything looks like a nail. I don't think we're happy to give, we're not, it doesn't give us delight somehow to give people medication or to take, it's not like we're pro medication. It's like, if that's what fits, then we're here to help and provide that.
Yeah, no, I'm going to butcher this quote, but I had a supervisor in residency who had said something like, we're medical doctors first, we're humans second, and we're psychiatrists third. And I think he was getting at exactly what you're getting at. If someone comes in the door and says, look, I'm having this crushing chest pain, we don't say, tell me about your mother.
No,
we
right.
say, go to the emergency room and make sure you're not having a heart attack. Right. And, the overlap between physical and mental illness is so profound in a couple of different ways. One way is that we just know that people who have physical illness are at higher risk of mental illness, maybe even just entirely separately. No overlap in what causes physical illness and mental illness. But I think what we're learning more and more is that there are actual overlaps in what causes some physical and some mental illnesses. And I think the most recent example of this is autoimmune encephalitis, which is increasingly discovered to be a rheumatologic condition that leads to everything from mood symptoms to psychotic symptoms and behavior changes. And we're learning more and more about this condition every year, discovering more and more autoantibodies. Even before that, we knew that thyroid conditions could also produce, prominent mood symptoms, whether it was mania or psychosis. And so I think this overlap between the mental and physical is something that we don't appreciate yet, and we're trying to understand more and more. But I think as part of an evidence-based and common sense practice, when we meet people who are having new onset mood and anxiety symptoms, we often think about physical exam. Do they have physical symptoms? Even if they don't have clear-cut physical symptoms as well, we often do screening lab work just to make sure they don't have common physical ailments that can manifest with psychiatric symptoms. Like you were saying, do they have a thyroid problem?
Yeah.
Do they actually have do they have a heart arrhythmia that is contributing to those palpitations that they're interpreting as panic?
Right.
And those are two examples that come to mind. But even the example of, are they using substances? Or could that be contributing? And seeing that as something that needs to be diagnosed and assessed as well. So
I know we'll talk about that a little bit more later on in the segment here, self-medicating, because that's a huge overlap and something that's, I'll share a funny part of my story as it relates to alcohol. But, I wanted to cover I did want people to hear that I'm not coming out of this experience like somehow thinking like everybody in the world should be taking Zoloft or Prozac or whatever. I really don't believe that. I just simply want to raise the bar for people's consideration of what are they willing to do to get results in their life, and to not edit out the possibility of psychoactive medication being a part of of enhancing their performance, plain and simple. I kind of stepped back, Joel, from this experience and said to myself, and I understand for lots of reasons why this can't be done, but ethically and whatnot, but I kind of wonder why drug companies don't market these as performance enhancing. And I wonder if they've got it all wrong, in some sense. And to me, I'm speaking really specifically to this subset of the population that, obviously we think of the world as somehow like ourselves. So I'm just being, projecting my own self onto this. But, people who are driven to achieve, type A sort of folks, ambitious, entrepreneurial, people who come from certain cultures, certainly. And I had, the doctor that actually kind of really woke me up, actually, the oncologist, I interviewed him and he said, let me tell you a story. My family, he's from Korea. He told this story about, if my parents thought we should be right here, then they would make us go right here. And so you mentioned culture and how there can be sometimes really simple explanations and behavioral things that we can work with in therapy that are causing either the panic, anxiety, or depression symptoms. And those are the first things we look for. It's are there simple things that you can do? okay, you're watching CNN or Fox News all day. Like, well, okay, maybe, well, you could take antidepressants so that you can tolerate that news dump, or maybe you consider like not doing it, or okay, you're drinking in excess. Alcohol is a depressant, so maybe we could consider. So usually there's a triage effect, right, where we are looking at like, well, let's do the simplest thing first. Let's get off of the alcohol, or let's deal with this, and then if some of those things are not clicking for the person, then of course, then we're going to recommend some medication.
Yeah, so that makes a lot of sense. I see triage, and I do some triage in that regard too, because somebody comes in and they're in massive debt and they have no plan to get out of it, and they're worried about it. Zoloft probably is not going to do the trick.
Right.
Or if they're in a terrible relationship, or even an abusive relationship, or they have housing insecurity, or they're hungry, or all of these things, then again, Zoloft is probably not the answer. So I think I learned from my training, where I worked with people from all walks of life and all backgrounds, that you're exactly right. We got to start with some of the most basic things and offer people some support in figuring out like life stuff. And as you come up the list from most severe, housing and safety, you get into exactly what you're getting into, which is, how much pandemic news are you watching? And are there
diet?
Things, yeah, exactly. And so that fits in well, I think, with the research on the benefits of these medications, because I think there's a pretty good meta-analysis that suggests that medications work well the sicker you are. And so for more mild symptoms, there's actually a huge evidence base that supports everything from mindfulness to exercise. I'm less familiar with dietary changes, but I think some people would advocate for that as well. All kinds of psychotherapies. It doesn't even matter too much what kind of psychotherapy for mild symptoms. And then as your symptoms get more significant, then there's more concrete evidence that specific treatments are more helpful. And so then you get more into evidence-based psychotherapies like cognitive behavioral therapy. But as you get worse and worse into that severe range, as you pointed out, like maybe you have problems concentrating, difficulties, motivation. It might be just really hard for you to make lifestyle changes. It might be really hard for you to engage meaningfully in a psychotherapy. And the evidence supports that that's where we see really profound benefits of medication. So
medication.
Yep. So for me, there's this balancing act of working with patients to understand what they're interested in, and also how strongly I might recommend something based on the circumstances that I'm seeing. Mm-hmm. So if someone comes to me mildly depressed, I might say, great, we've got this huge range of options. What are you thinking? Right. If someone comes to me seriously depressed, suicidal, et cetera, then I might say, look, we've really got to do a couple of key things here, because these are the things that are proven to have serious benefits, and medication should be on this short list of things that we discuss because of its, the severity of the situation.
Yeah, not messing around at that point, just telling it straight, like this is what can get the results.
Exactly. But what's interesting, I think, is, again, not this high randomized control trial stuff, but maybe you've heard of the book Listening to Prozac.
Yeah, Peter Kramer.
Yeah, exactly. He has two that I've read. The first was Listening to Prozac. I'm forgetting the name of the second one. But his story in Listening to Prozac was that there are a lot of these people who don't have severe psychiatric disorder. They're actually doing pretty well in their lives, but they are tense or rigid or have some other difficulties. They tend to worry.
Angry.
And in his practice, they're angry, they're irritable. And in his practice, he found that offering some of those folks medication actually was really still life-changing for them, even though they didn't have these traditional severe depressive disorders. Yeah. Right. And so that's what I think is interesting about this conversation, and what you're getting at is like the potential role for medication across the spectrum of difficulties. And go ahead.
Yeah. Across what I would say like a spectrum of subclinical difficulties, right? Things that might not meet the criteria, and you might not meet all those check boxes. And my I guess my mission that I'm on, the soapbox that I've built here, is like telling people, look, why would you want to wait until you are checking all those damn boxes? Like, you can kind of see yourself heading for the edge. Like there's so much time, and I just want to advocate for people to use the time that they have and avail themselves of help, no matter what it is, and not judge what it is, and just see if it gets results. Like I'm just open to seeing what works, and I think that's the lens we should use. Obviously, research plays a part in that too, because good research should be focused on does this actually work? Not am I trying to prove that this drug is good or bad so that people will buy it or not. I think we should be curious about things that don't work too, and stay open. I want to pivot a little bit to kind of what practically people might expect, because I want this to sort of be an inside out sort of conversation that some people may not get to have with a psychiatrist, right? Like to understand like what it's really like to talk to a psychiatrist, people who've not had experience with it, people who have maybe the HBO experience of it, and maybe this prejudice against like how it might be. How often would you say, because for me, my experience, Joel, was, I was lucky. I was working with a colleague that was prescribing and treating me. And so I had a close relationship with this person in that, I was able to text or call and got a quick response. That's not everyone's experience. And I know managed care sometimes, certainly you're one of, sometimes, I don't know, 50, 60 people that this psychiatrist might be working with. So what should people expect in the first month? Because it's especially important, I found, to pay close attention the first month. It can be bumpy getting onto some of these medications, trial and error a little bit with dose and with type of medicine, and then side effects, which we'll get into. So what should people expect?
Yeah, so you brought up a number of useful points. So one I wanted to talk about is the process of being open to a medication. You hit the nail on the head. So, there's this anti-psychiatry movement. There's a lot of attempts to take down medication. And what I think surprises me every time is that the use of medication stands up to rigorous testing every time in psychiatry. And so that means that when you look at thousands of trials, tens of thousands of patients, integrate that all into a single analysis, you continue to find that these medications have benefits for depression, for anxiety, for bipolar disorder, et cetera. And sometimes the size of the effect, how beneficial these medications can be, actually outshines a lot of the medications we use in other areas of medicine. So I think that people subject psychiatric medications to a bit of a double standard, so like people get prescribed a blood pressure medication. It doesn't quite work. They have to try a different one. That one doesn't quite work. They wind up on 2 blood pressure medications. The blood pressure comes down a little bit, but they still have a problem. Maybe they still have a stroke or they still have a heart attack. And nobody says, oh, well, we shouldn't believe in cardiology. Cardiological medications don't work and you have to try more than one. And why don't we know exactly which one works? And why don't they work 100%? Well, the same thing, people take statin medications and they, maybe they have a side effect, so famously some statin medications were causing some like muscle pain and some other things, and people were lowering the dose. And again, there wasn't this backlash, oh, we shouldn't believe in statin medications, or why don't they prevent every heart attack and things like that. So you're exactly right. We know that these medications can have a benefit, that they are different than taking a fake medication, that even if you don't know you're taking a real medication, even if you don't believe it's going to be helpful to you, they still work for many people, but not everyone. And furthermore, it's just like, you got to figure out what blood pressure medication agrees with you. You have to figure out what psychiatric medication agrees with you. And it's a bit of a trial and error process of finding the right medication and right dose, because we're not there yet. We haven't developed all of the tools we need to truly personalize out of the gate. We don't have genetic testing. We don't have brain scanning that can say, oh, this is the medication for you. So I think being open-minded about medication means being open-minded about the process of figuring it out and, collaborating with your doctor to talk about why this medication, what are the potential ups and downs, how will we know if it's working, what if it doesn't work? What are what might we try next, et cetera. So,
right. Well,
so that was the first point. Go ahead.
Well, I want to just jump in. I know there's more you want to get to, but speaking of genetic testing, and I didn't remember to bring this up or to find this, but I did take a genetic test. My provider did give me a genetic, like a cheek swab, and then you may be familiar with this. I know it's nascent. It's not a It's not a highly developed thing, but it at least tells you based on your genetic profile, and they're building a more expansive library. So I think every month, every year, it's getting more intelligent, but they tell you these are going to cause really negative reactions. Stay away from this class.
So I have strong feelings on this one. So with my esteemed supervisor, Dr. Ron Winchell, I helped host American Psychiatric Association debate about the clinical utility of genetic testing in psychiatry. And trying to remember who the panelists were, but I think one actually was an advisor to GeneSight, which is one of the companies.
I think it might have been GeneSight. Yeah.
Yeah, there you go. So, and full disclosure, I've actually done some genetic testing on some of my patients, and I'll explain some of my thinking. So there are really two categories of information that come out from genetic testing. One has to do with the metabolism of drugs, and that's looking at these proteins in the liver that help break down the drugs. And people have a variety of these things. You know, one person can have fast metabolism, another person can have partially slow metabolism, et cetera. And there is some evidence there, actually, that knowing the metabolic profile or the genes related to metabolism can help people select starting doses of medications, and can also help us understand why some people might be having side effects. But a somewhat reasonable alternative to that is actually just starting at low doses of medications, going slowly and being open-minded about the potential for side effects or effectiveness at low doses. But nonetheless, I think getting genetic information about metabolism, and there are some international guidelines that aren't too popular, but you can find them that say, oh, if you have this combination of metabolic genes, then you want to start this drug at this dose instead of the recommended starting dose, for example.
I'll just say, Joel, like I think that for me, like the fact that this doctor was willing to do it with me, even if it's marginal benefit, like on the science end, like somehow it relieved, maybe it was placebo effect, but it relieved my sense of anxiety about taking medication. It was like, oh, I'm not going to be taking like Clorox. You know, I don't know what kind of anxiety, you know, I don't know what I would be afraid of, but I think people have this fear, and I definitely have this fear, like, what are you giving me? What the heck is this medicine?
So you raise a great point. I do think that a lot of doctors, a lot of clients come into the practice sort of wanting this done. And then I think I will now share with you what I think is the potential danger of doing it, but I think in the right hands can be reasonably done. And that is this other set of genetic testing that has to do with things like the receptor in the on nerve cells that, the medications bind to and things like that. And so you were correctly pointing out, like this our knowledge about this is growing all the time, but sometimes these tests make clear recommendations about this drug will work and this drug won't work. And they maybe even color code red, yellow, green.
Yes.
I think this is often those things are based on like 30 women in one study in Japan had this response in depression.
Wow.
And like that will be the basis for that recommendation. Yeah, right. And so then a patient comes in and says, well, I can't take Zoloft because it's in the red, even though Zoloft is an extremely popular, effective, well-tolerated medication that actually has just as good a chance of working for this individual as something else. And so that's the challenge that I face as a prescriber is, how you blend a personalizing recommendation with, some weak evidence-based, and they'll say, oh, you should take this third-line medication. And I'll say, look, we really don't want to start here. The best thing is still. So that's the challenge, I think, is balancing like what useful genetic information about metabolism can come out to guide selection and dosing versus what sort of overly interpreted data about the serotonin transporter is presented that can like lead people astray.
And this was the lesson for me, Joel. I'll just say it really bluntly, like trust your doctor. Like there's a certain point, like especially as a provider myself, I think people like me who are or let's just say self-driven or leadership-oriented people, they tend to think that they can find the answer themselves. It's like, part of the cluster of symptoms or the causes in my life that led my brain to be conserving energy, right? That's what depression is in the brain, right? It's just the brain going on conservation mode. part of the behaviors and thought processes that led to this are the same things I was trying to do in my attempts to get out of depression. Oh, I've got the answer. Oh, I'll do the research for my endocrinologist. I'll bring that research in and tell the endocrinologist what I have. Holy, okay. At a certain point, I needed to just realize, my medicine here is to actually relax and let other people tell me what the answers are sometimes, and trust your doctor.
Yeah, it's a balancing act, exactly, because I do really value, my clients are the experts on themselves.
Right.
And I really value, I need to know what they think, what they feel, what they're interested in. I want to know what they've Googled, what they think looks like it might work for them, what they're really afraid to try. And I keep coming back to this word collaboration. And that's really what I, as a provider, want to have with my patients, which means I don't think they should sit there and just do what I say. But nor is it, sometimes it's not so helpful if they come in with the printout and say, this is it.
Right.
And, often in those situations, that might be a reasonable place to start. I'm certainly not going to dismiss someone who comes in with a strong idea about what they want to try, as long as it's also, in my mind, reasonable. If I'm going to lose my license for prescribing it, that might not be the place for it to start. But, as a way of sort of developing a rapport and valuing a patient's input and trusting their own gut about what might be helpful, that's certainly a good place. But sooner or later, we want to come into a conversation and start figuring it out together and, exploring together what are all the things that are going to work for this person at this time.
It should be a collaboration, right?
Yeah.
I want to be aware of our time and kind of jump to a couple of things here. One that I referenced earlier here is this idea that people, I don't know what the rates are statistically, but people are self-treating, right? As much as people think that they do not have an issue, a mental health issue, but then they're going to the bar every day or every other day, or their alcohol consumption is spiked during COVID. We know that is actually happening out there. And obviously people using marijuana or other self-medicating types of things. How do we differentiate? I had some questions for you about how SSRIs work versus SNRIs, selective norepinephrine reuptake inhibitors versus selective serotonin uptake inhibitors. But I want to jump right to and we can talk about that a little bit, but the difference between somebody saying, well, I just need a glass of wine or maybe 3 every day versus maybe you should consider you have an anxiety disorder that you're treating with a depressant, alcohol.
Yeah. That's a tough one. So, okay. All right. I can't help but address, I hope briefly, 2 other questions. So the first one was going back to how often do you see your provider?
Yeah.
Oh, I can't help but speak to this one really quickly.
Yeah.
And that is, the American healthcare system is tricky. And, a lot of psychiatrists, because of the reimbursement rates that they're paid, don't accept insurance. And then clinics or other places that do accept insurance might have a lot of patients, exactly to your point. So I think that individuals' experiences are going to be highly variable in the amount of attention they get. And some people really are going to get 15 minutes every few weeks, and other people are going to get 45 minutes once a week. And so I would say, just like we want to develop a personalized solution, approach for medication and psychotherapy, we also I encourage people to try to find a circumstance that works for them. And sometimes, family practitioners and primary care doctors are familiar with these medications, have availability, and do a fantastic job. And that might be a good solution for a lot of people. Other times there might be clinics that are just community clinics that really work well. And then finally, if you have the resources, if you have the insurance, private practice psychiatrists can also be a bit more flexible and offer you time and the frequency of meetings that work for you. But usually I would say, 45 to 90 minutes for an intake, and then meeting every 2 to 4 weeks as you start a medication, or at least checking in on the phone or doing some other things to make sure it's going right. So I hope that helps.
That's great. Yep.
Yeah.
And even nurse practitioners might be the person doing the checking in between appointments. And that is so critical to say, this medication is causing me to not sleep. That was my experience. Severe sleep disruption on an SSRI. And then it had to be corrected or actually augmented with mirtazapine, which is Remeron. And, we won't have time to get into that, the nickname for that, California rocket fuel, which is not the combination that I'm taking. It's not a high enough dose to have that sort of effect, which I think is referring to the rocket fuel, right? You're listening to the Soul of Life podcast with me, Keith Miller. Every week I bring you a new episode that hopefully inspires you to reflect more on who you are and who you want to be in this rapidly changing world. If this time we share together moves you somehow closer to who you are or lights up parts of you that have been unplugged, I want to hear from you. And please share the love. Take a moment to find the Soul of Life podcast in the social media where you hang out on iTunes, Facebook, Instagram, or YouTube, and let me know who you are. Which is, I think that they were referring to treatment-resistant depression, which I did not have that, but thankfully. But so anyway, I know where there's a bunch of questions out there.
Yeah, I think that term was dubbed. I think that combination of Effexor, venlafaxine, and Remeron, mirtazapine at full doses was dubbed by Stephen Stahl, who's this, I saw once referred to as a celebrity psychiatrist. And he has a very popular book on how to use psychiatric medications and also how he thinks they work. And it was used in this really big community study called STAR-D. I think that was one of the second or third line treatment options, and it showed some benefits. So yeah, people have thought for its effectiveness and also for the diverse ways that it affects brain functioning, have dubbed it California rocket fuel. So that's a good one. But okay, so I'll leave SSRI versus SNRI alone, and I'll get into the issue of our coping strategies, whether it's substance use or something else. And again, it's for me, it's on the spectrum. And so for someone who has a few glasses of wine a night, I might ask them how that's working for them. And I might ask them, when's the last time they saw their doctor and had their liver functioning checked, or, whether it was causing trouble. People often think alcohol helps with sleep. We know it helps people fall asleep, but as you metabolize the alcohol, it actually leads to lower quality of sleep disruption, and makes people feel often tired, hungover the next day. So for people at the extreme end who are having way over any recommended limit, or having clear problems, that there I might make a firmer recommendation and say, look, this looks like a medical problem. You're causing your liver injury, whatever it is. But for people somewhere in the middle, I might just work with them to say, and how's this working for you? What are the ups? What are the downs? Have you thought about reducing it? What do other people think? And this is a more motivational interviewing style approach of just really understanding the role of alcohol in that person's life. And what I sometimes interpret to that person is hey, you've already made the decision that chemicals actually are helpful to you. So alcohol is just another drug. People call it a drug. So you've already made that decision. So why don't we try to evaluate the ups and downs of this way of using a chemical and see if there are potentially other medications or other things, whether it's a nutraceutical over the counter or if it's a prescribed medication, and just see, what are the ups and downs of using that, and and try to decide what's helpful for this person, what's going to work in their life, and if the alcohol is causing a lot of trouble with a spouse who thinks they're drinking too much or causing some other problem, then maybe, right, you're exactly, then maybe we should be open-minded about other ways of coping with stuff.
Yeah, it's a really nice way to present it, Joel. A lot of people, I'm sure, and I know you're experiencing this too, because we've talked about it, our clients are coming in saying, I'm really fine because, ever since I started smoking weed every day or a couple times a day or whatever, everything seems to be better. And so I guess, and I want to preview this, that I'm going to dive into this a lot more in depth to talk about sort of the pros and cons from a scientific perspective and how it works in the brain long term, especially in the developing brain with teenagers and young people in their 20s. What's your take on, when somebody comes in and says they're using marijuana?
Yeah, I wish I had more of a research base to make recommendations. I think that's one of the limits. The federal regulations that we've placed on marijuana research are really onerous. It's really made it hard. And so there's just not a lot of good research about either CBD or THC. And both its effectiveness for symptoms and its long-term effects on adults and children. So the first thing I have to tell people is, hey, I wish I knew more about this. I really love to be able to say there's a full body of scientific literature and I've read it and here it is, but there's really not very much. So that's the first thing I have to be honest with people about. And then the second thing is there are a few randomized controlled trials at this point of CBD for anxiety, for example, and also THC. And so far, the major finding has been that THC consistently makes people feel high, which they like. But it doesn't seem to have a separate impact on mood and anxiety symptoms. So a lot of times what I say to people is, yeah, of course you feel good. THC makes a lot of people feel pretty good. Is it a treatment for your mood or anxiety problem? I'm not so sure. And so then I'm really in the position again of like getting into the weeds with them and saying, how is this working for you in your life, right? Yeah, getting into there we go. So, and that's where I have to leave it. The good news about THC use is, again, there's not a lot of evidence, but I think in adults, there's not a lot of evidence that it's really bad for you, though I think people don't appreciate that you can absolutely become dependent. I work with a lot of people who have frank marijuana withdrawal syndromes, where when they try to stop, they get irritable, they can't sleep, they can't eat, can't concentrate.
Yeah, this idea that there are no upper limits to use of marijuana or no addictive qualities, and there's a big debate we can talk about, but about what addiction is. But that's not true, right? We do see side effects. All drugs have side effects. Even good drugs, or even things with a good effect profile can have pretty
potential side effects.
Significant, yeah. I know we're limited on time a little bit, but I want to ask you about ADHD and kind of talk about children in this cross, diagnostic, trans-diagnostic issue with ADHD, depression. How do people kind of differentially diagnose that in themselves and children? The idea of medication for children in general, I have a story to tell about that. But can you quickly kind of touch on the idea of why side effects specifically for SSRIs with Zoloft? What are the other SSRIs? Paxil, is that right? Prozac. Why is there sleep disruption? I think a lot of people, or some people, I've heard just kind of throw their hands up and say, "See, that's just crazy. Like you're giving me this to help with these symptoms, so I'm okay with that. But you're giving me like." I'm going to become have insomnia because of this. So at that point, they're just like, I'm out.
Yeah. So it's interesting because people have idiosyncratic responses to the serotonin reuptake inhibitors, and they go in opposite directions. So I actually tell people when I'm discussing the potential side effects of an SRI or SSRI like Zoloft, I literally say, some people take this medication and actually feel more awake. Other people take this medication and it makes them feel more tired. And so my first line intervention for that is just to move the medication to the morning if it wakes them up, and to the evening if it makes them sleepy. And it's complicated because depression itself can have idiosyncratic effects on sleep. Some people experience increased sleep. Other people experience significant sleep disruption, difficulty falling asleep and staying asleep. And so occasionally, when you successfully treat the depression, the sleep problems caused by the depression get better. But sometimes, I think in one study I looked at, they're one of the most common residual symptoms. So sometimes people's mood and energy and other symptoms improve, but they have trouble sleeping. So this is one of those areas where communicating with your doctor, collaborating with your doctor, trying to understand in your particular case the sequence of events. Were you having trouble sleeping while depressed and it just didn't get better? Were you not having trouble sleeping and it actually is associated with the medication? Really trying to figure that out for you can then help you and your doctor decide what to do next. And in the case where it's clearly tied to the medication and moving the timing of the medication doesn't work, that might be a reason to consider an alternative SSRI. In the case where it's a residual symptom of your depression, and your depression is otherwise improving, that might be time to consider I'm targeting sleep specifically, whether it's with CBT for insomnia, if there's not good sleep hygiene habits, or if it's considering a sleep aid like mirtazapine, Remeron, another medication that more reliably tends to make people sleepy.
Yeah. And you remind me of an important point that all of this, if anybody's listening to this and they're just glazing over with like, well, see, that's the reason I'm not going to go see a psychiatrist, because all these details, like, it just opens up. If you're already struggling with anxiety or feeling overwhelmed or intolerant to sort of novelty, this opens up a Pandora's box. Like, hello, like I'm already struggling with these things. So now all these choice points. But this is what therapists are for. This is what we do in therapy with folks, is interact with psychiatrists on behalf of the client, our clients, and oftentimes provide some of these kind of backstage, behind the scenes kind of shop talk, basically about like, well, what's this and that? And then we can translate it to our clients and say, well, and just be supportive and encouraging, because it often is overwhelming. Like if I go to a cardiologist, there's a person I interviewed who had open heart surgery, and he was interviewing cardiologists before he had this surgery. And, one cardiologist said to him, like, well, here's what we're going to do. And he outlined, kind of like gave him a PowerPoint on like what actually happens in the surgery. And then the other cardiologist said, listen, I've done this 1,000 times. I could do it in my sleep. It's going to be fine. And it's going to be successful. He chose that guy who didn't give him any of the details. He wants, sometimes we just need to say and hear like, hey, it's just going to be okay. And just,
yeah. So I think my personal approach, I try to reflect that, because I think one thing that people can do is when there are a lot of choices, I think some psychiatrists or some doctors in general can kind of lay out those choices and put it back on the patient to decide. And so I try to do a best of both worlds approach in my own practice, where I say, hey, you're in a great position. There are actually a lot of things we can try, all of which are likely to help you get better. And I'm happy to talk to you about every last one if you want to. But if I were in your shoes, I'd probably just choose this one. And that way I'm giving them like both the knowledge that there's a lot of options, positive expectancy, because I'm saying really any of them might work, but I'm also giving them a concrete recommendation about what I would choose and why. So that way, if they want to go, oh, okay, that one, then we've got a great place to start.
Yeah.
And so that's my personal approach. But I really agree with you that, psychiatry, in its attempt to be personalized, can potentially be overwhelming. And so that's why having a good relationship with your doctor, and even just a matter of personal style, like the way I go about things might just not be the way that some clients want to go about them.
Exactly.
And so, in addition to finding a doctor who kind of works in your schedule and sees you the amount that you feel is helpful, you might just also want to talk to people until you find someone you click with, because that positive relationship is, even when it's medication oriented, is still probably one of the most important aspects of the treatment.
That's right. And then even that decision point can be overwhelming for people who are struggling in their relationships. There's, one of the things they're struggling with is like, well, they can't really discern who's my ally and who's my friend. They're making friends with people that really should be not friends with, and all this. So again, that's where therapy and behavioral interventions come in. We can help with that. Can you speak about, because you do treat adolescents, I think you treat children with psychiatry, and I'll just share this quick story about a family member, a young girl in my family had an issue with anxiety, and the family was describing this symptom as really like tantrums, like ever since like age 2, but the tantrums really lasted like every day and multiple times a day, debilitating kind of tantrums for 5 more years. Like, so the terrible twos that everybody talks about, sort of saying no to everything, inability to tolerate new things, right? Real sensitivity to change, difficulty with demands like going to school, brushing teeth, that sort of thing. So that lasted for 5 years, and the family was kind of organized around, or disorganized, I should say, around kind of naming this as like, well, just problematic child behavior. And despite like all sorts of interventions, behaviorally, compassionately, counseling, family counseling, even sensory types of interventions that are reserved more for kind of less verbal children. and nothing was working. So after 5 years, the parents in this family really decided, hey, we're going to try psychiatry for our child. They had the child start taking Zoloft in this case, and like it was like night and day, Joel. Within like 2 weeks, they had their little girl back to kind of being responsive and able to tolerate kind of the normal disappointments of every day. But I know this family struggled a great deal with their fear that psychiatric medications might somehow harm the developing brain of their daughter, and in this case, they needed results. And so they were able to get, they overcame that fear.
Okay.
But how do you handle that with kids? Do we know much about how it affects the brain of children?
I wish we knew more. And I am with people that I tend to take a conservative approach to the use of medication. But the wrinkle on that for me is, going back to this idea that the forcefulness of my recommendation is often proportional to the severity of the problem. Even still applies in childhood. And, we do have research to show the benefits of a wide variety of psychiatric medications in children as young as 6, and some experience using those medications in children even before the age of 6. And what I try to frame for people is Prozac, for example, which I think is the prototypical serotonin reuptake inhibitor, has been around almost 40 years now. And many people started it in the 80s as younger folks and have been on it successfully for decades. And of course, we don't have a 40-year study, but the FDA does this post-marketing surveillance where after a drug is approved, you still report adverse events related to it. And so my hope, my belief is that if there were some really clear developmental problems that emerged because of these medications, my hope is that we would have detected them by now. But it's a bit complicated because the kids who needed those medications in childhood are also the kids who are a bit at risk of having problems in adulthood. So that's one thought I have, is I try to reassure people that I think any serious and obvious negative developmental consequences, my belief is that they would have been apparent at this time. Yep. So that's one thing I say. The other thing I say is, well, what are the developmental consequences of multiple daily tantrums?
Exactly.
And how does that affect someone's self-concept, self-worth? How does that affect someone's ability to develop relationships, engage in school, manage stressors? And so I try to note that behavior has a significant psychological impact. And more than that, I don't know what the impact is on the brain. I don't know if being so depressed or so irritable or so inattentive or whatever it is doesn't have its own.
Well, certainly presents learning difficulties, certainly presents relationship difficulties. And as you pointed out, the self-identity, like people basically writing that person off, or in this case, a child, as irritable, grumpy, mean, and that wasn't happening, thankfully, in this particular family's case. But it was certainly breaking down the family functioning. And, if the family breaks down, then clearly you have more tragic things unfolding than dealing with the potential of, well, should I take medication or not? Like the tragedy is already unfolding. It's out of the gate.
Yes.
So why not get results? So again, back to sort of my mantra here. We'll end on this note, because you've done research and have familiarity with ADHD, as a lot of people know, that's a diagnosis that when I was a kid, I don't think that was around, right, Joel? Like when I was, in the 80s, I don't think ADHD was really being, maybe it was starting to be, but it's now like a first line sort of intervention for a lot of child psychologists. So can you tell the difference between a child that has, this gets back to our transdiagnostic sort of question, how do we rule out severe anxiety disorder or moderate anxiety disorder, which interferes with attention, versus ADHD? Because the drugs are very different.
Yeah. So That's, I think, the benefit of going to an experienced clinician who works with children, and whether that's like a pediatrician who has experience in this area, or a developmental pediatrician, clinical psychiatrist, clinical child psychiatrist, child psychologist. This is an area where I think a full evaluation by a knowledgeable clinician is the best thing that we've got. And so how do you do it? Well, you systematically interview the parents, you collect a family history, you interview the children. Sometimes you might obtain information from teachers. You might have them fill out various forms. You can have parents fill out questionnaires as well. And so you go into it thinking exactly what you were thinking, that in children, difficulties paying attention could be the result of a problem with mood. It could be the result of a problem with anxiety. It could be the result of autism spectrum type problems. It could be any number of things.
Could be a hearing problem, right? You
exactly.
Never know.
Yeah. And so the good news there is, I think, is that, schools have gotten really good at doing hearing and vision testing. But you're exactly right. Especially earlier in life, before age 4 or so, we definitely think about physical impediments that could be getting in people's way, like marginal hearing, vision difficulties, et cetera. So you hit the nail on the head there. Your goal is just to be as thoughtful and systematic as possible. And comorbidity, having more than one condition is definitely more common than not. And so a lot of kids might both have ADHD and anxiety, ADHD and a mood problem. And so then an experienced clinician is useful in sort of helping establish a treatment priority. What is the bigger issue? What needs to be treated first? How should be addressed? And developing a treatment plan over time that ultimately addresses all the challenges, but sort of has a starting point and a process. And interestingly, you raised a point, different medications. There is one study that looked at kids with both anxiety and ADHD, at least one study coming to my mind, and stimulant medications actually helped with both. Oh. So, yeah. And this was a study comparing a non-stimulant ADHD medication to a stimulant ADHD medication. Everybody get less anxious, but this non-stimulant medication, atomoxetine, Bernanke Strattera, helped people get a little even more less anxious. So it's curious. The stimulant medications, people anticipate a lot of potential negative side effects. For many kids, they actually can improve frustration tolerance, reduce anxiety, and then improve core symptoms of ADHD like attention and hyperactivity.
Right.
So they are useful medications, and yeah, definitely worth considering even when kids might have more than one issue going on.
Yeah, well, really great information. I hope people find this. I think we packed a lot of information in here, and I'll just sort of end on this note that we've been talking about the whole time, that people will benefit from paying more attention to themselves and involving experts to help them pay attention to things that are happening at the physiological levels in their bodies and in their minds. Yeah. I had somebody say to me recently, we have this saying that we say we have a body, or we think of our body as somehow separate, but actually we are embodied. Our mind is a function of our body. You can't take the mind out of the entire body, unless you're in a sci-fi movie with Keanu Reeves or something. But that's another topic for discussion for another episode. But thank you so much, Joel. I really appreciate your work that you're doing and spending the time here today.
Oh, you're very welcome.
Thanks for listening to The Soul of Life. This is Keith Miller. Oh, and don't forget, please leave a thumbs up or a like for this episode wherever you're listening, so that others like you may find the soul of life. I mean, really, it's not every day you get to share the soul of life with someone. Okay, so you can post a comment or question on souloflifeshow.com. I'd love to hear from you, and please subscribe now to get the next episode. I look forward to sharing more of my soul of life with you.
I like it, and it's not harsh to my eardrum.
All right, I will go.